It was a routine outpatient visit in clinic the other day. It was just after lunch, a Tuesday. I had been on call the night before, managing patients with acute stroke overnight. I was a little tired, hadn't slept much. Honestly, I was more bummed about how my fiance's fellowship has been on her. She's having a much harder time than I am. In clinic, I pull up the list of afternoon patients. My first patient has been checked in. A new patient here for a second opinion of cerebral white matter disease. I'd gotten to the clinic a few minutes early to see if she'd had her vitals checked, and if she'd brought any neuroimaging with her. She did, and they were uploaded onto our electronic server. 3 brain MRIs over a period of 12 years or so. I opened them up on my desktop computer in the back of the clinic and reviewed them, one by one, looking for signs of old stroke, mentally measuring the severity of her white matter disease, seeing if there had been any subtle hemorrhages, any arterial abnormalities, and so on. Overall, not a terrible series of scans. A few small strokes and signs of long-standing tobacco use or hypertension. I log off the computer and walk into the hallway where a woman is pacing. I politely nod to her and turn to face the door where my clinic room is for the afternoon, the room where my first patient was supposed to be placed. The room is empty. The woman who'd been pacing up and down the hallway follows me in. "Oh, you must be Miss So-and-so," I say to her. "I'm Dr. Siegler, one of the vascular neurology fellows." She shakes my hand with a firm grasp. "It's about time you showed up," she snorts. "Have you been waiting long?" I ask. "I'm sorry if you have. I saw your appointment was scheduled for 1 p.m. I looked down at the clock on the computer. It was 1:02. She fumes. She tells me, "I got here at 12:30 p.m. and waited for half an hour." I thank her for arriving early. It gives us more time to talk than if she'd arrived late. "Doesn't matter," she snaps. "I know you don't really give a shit." I absorb her frustration over the next 5 to 10 minutes while I apologize further for being late, and try to navigate through a verbal account of her medical history. I'm a little appalled by the encounter, and either because I'm too tired to fight back, or too distracted by how much worse things could be for me, I pretend that it doesn't bother me. I carry on with the interview. She's certainly not the first upset patient I've seen, and nobody ever goes to the doctor because they're happy. As mad or as devalued as I feel when this happens, to tell you the truth, I do feel really sorry for these people. And I remember that, above all else, I'm here to help them. Today's episode is not about patients. It's about providers, the physicians, the nurses, advanced practitioners, and other healthcare personnel whose needs and emotions are largely ignored. Because it's hard to put your needs first when your sole job is to help others who are in even greater need. While there's been a paradigm shift in the last 20 years when it comes to quality of life for those of us who work insane hours, 80 to 120 hours a week, and deal with extremely sick people in extremely unfortunate situations, I can't deny that it doesn't still get to us. It all adds up, and it still breaks us down. This week, you'll hear from 2 resident physicians about resident burnout, how they deal with it, and what they've done to overcome it. I'm Jim Siegler for Brainwaves in Philadelphia. Don't burn out on us yet.
From the top. Hi, I'm David Manley from Durham, North Carolina. Brainwaves is supported in part by Audible, home to nearly 200,000 audiobooks. There's not enough time in your day to read anymore. That's why you're listening to a podcast right now. So make some time to pick up a good book and listen to it on Audible. You can get your first month and first book for free by signing up on audibletrial.com/brainwaves.
Joining me this week for the show is John Best.
My name is John. I'm one of the second-year neurologists here at Penn.
He's been here in Philly for 2 years, a transplant from the West Coast, but originally from Oklahoma.
Like the musical.
And Lindsay Raab.
My name's Lindsay. I'm one of the other JARs, or second-year residents at Penn.
She's originally from Wisconsin, but now lives here in Philadelphia too.
And I spent a significant amount of time with my 2 dogs.
Let me start by saying that both John and Lindsay were incredibly generous enough to join me in the studio, the basement of my house, on their post-call day, in the busiest year of their residency, to talk about this topic of resident burnout.
I may not listen to this because hearing your own voice is very strange.
You're always a very different pitch.
Yeah. it's important to, as a resident, to learn who you are as a person and learn what kind of emotional connection you can and cannot handle.
One of the biggest challenges faced by physicians in their training is the steep learning curve that comes with the job.
I think when starting, you don't even realize how much you don't know. And so clinical competence is overwhelming, but I also think learning how to function as a resident is overwhelming because you don't really learn that as a medical student.
And that's the truth, the scary truth. Medical school does not prepare you to become a physician. It prepares you to recognize medication interactions and to know what is the juxtaglomerular apparatus, or how isoproterenol acts on cardiac myocytes.
Your knowledge is useless. Like, you have a lot of knowledge, but you don't know how to use it. And that's very frustrating.
So most trainees begin their careers with this imposter syndrome. They feel as if they don't belong, as if they're inadequate, like they didn't deserve this degree of responsibility. And then, things only piggyback on top of each other.
It was my intern year, and I had a patient.
We go to a lot of stroke situations.
Didn't know as much as I should.
Then someone died 4 minutes later.
Various complicated medical problems, and he was finally stable.
And those are some of the sickest patients in the hospital.
And I was the intern on the day float team, so I didn't know him that well.
Devastation that a patient may be experiencing.
We got all the right images, got a bunch of labs.
But at the same time, it's very difficult to see people going
right
through.
When I was about to sign out, he coded.
It's like a war zone kind of thing.
Eventually passed away, and
those kind of things really mess you up, and those are
I guess I was so overwhelmed by just the sheer overwhelming nature.
Slowly and maybe shed a few tears.
Emotionally overwhelming, and the most overwhelmed I've ever felt. Just so overwhelmed.
It really breaks you down. Mentally, physically, emotionally, but you're dealing with it, right?
Honestly, I think that crying is okay. And I think that when we talk about things like having an emotional reaction to something, I think that's a part of the normal experience. I mean, how people process their emotions can be different, but I think that everybody at some point has felt devastated by what they've seen or what they've gone through. That's just the nature of gathering the experiences that we have. I think it's more a question of how you respond to those.
I think every single resident would say they've cried. And I think there would be more than 75% that say they've cried more than once.
Definitely.
But sometimes crying it out, or venting to a friend, or using any other emotional release, sometimes these don't even work. They aren't even relieving. And that's where burnout begins. Burnout has been described as, and I quote, a pathologic state of emotional depletion. But it's not as simple as that. According to some experts, burnout has 3 dimensions. First, emotional exhaustion, in which overwhelming work demands deplete the individual's energy.
I can give you a situation which was the most overwhelmed I've ever felt.
Second, depersonalization and cynicism.
Just a disconnect between us wanting to care for patients,
in which the individual detaches from the job because you're constantly facing horrible situations.
Then someone died 4 minutes later.
And third, feelings of inefficacy.
You worry about if you're saying everything right, and
in which the individual perceives a lack of personal achievement.
I didn't have a lot of utility.
But it's not like burnout's a staged process, or that you have to meet all 3 of these criteria. There are varying degrees of each sort of symptom, and they exist along a spectrum. And it can manifest in a number of ways for a number of people, depending on your personality.
I think that burnout is a slower process. The word is wrong. You're smoldering, you're not burning in a way. And it's not like a big firework. It's not like you go out in a big flame and flash of lights, and you totally could, but that's a later symptom.
I think when I've felt burnout, I feel apathetic, and I have to consciously remind myself to not feel that way, but just recognize that I feel burnt out, and that's why I feel that way. But I just think it's a lack of emotion towards whatever's in front of you, which
is dangerous because you have really sick people in front of you.
There's a lot of pressure out there for resident trainees.
Learn a lot and do a good job and, take care of my patients, but kind of get on to the next level.
I have a very specific example of whenever I was in the cardiac ICU, where I basically arrived and then someone died. And, I was in doing this code situation, and it was very emotionally just jarring because, it's a situation where the person would become conscious while we were doing CPR, and then they would become unconscious when we were stopping, and they were like attacking me while I was trying to save their life.
So many external forces.
Feeling like I, didn't know as much as I should, and feeling like I was never going to get to that point. That's what residency is about. But I think the first time you experience that, it's terrifying, and you're always looking at the people above you thinking, am I ever going to get there?
Just draining. It's really draining.
Because of medical school and residency, I know I've personally missed a number of weddings between my closest friends, at least one high school reunion, a college reunion, and so many birthdays. I think the last time that I celebrated my own brother's birthday with him was in 2004, the same year that House debuted on Fox as one of the most popular medical shows on television.
For a long time, and
I get bonus points if I act like I care.
So it makes me wonder if I were given the chance to go back and do it all over again, would I? And I love my job now, but I really don't know.
Would I go back and start over again if I was 20 when I, started on this pathway? I think the answer is yes. Would I start medical school right now? I don't know that I would necessarily, just because of now I know how much time and energy it takes. And I think at, 28, that would be really hard to do, because then it's your 20s and your 30s. But I really like being in medicine, and I can't imagine a different job. And so if I would go back and do it all over from the start, I think I would. I don't know that I would start at age 28.
I think for me, the big thing is that I am in general very happy in medicine, but I think I also could have been happy in other places. And if I turned back time and had an alternative, would I be interested in an alternative? I think the answer even at the time was yes. And I think that's something that that whenever we talk with college students who are interested in medicine, we always tell them, this is a long path. There's a lot to it. If you could be as happy or happier with another path, there's no reason to choose this particular one.
And I sometimes have these conversations with my family because no one else is in medicine. They remind me, when you were 22, you were going to do absolutely nothing but medicine. And I think I would have always thought, what if I hadn't done medicine? And so I'm very grateful that I did, and I'm happy that I chose this path. But it's definitely not something you should go into if you're kind of hemming and hawing about it.
So how can we cope with this? This episode can't all be just about horror stories and struggles from age 22 until basically your 30s. There has to be a silver lining. And for Lindsay, it was the support of her friends and their shared experiences.
Honestly, the biggest thing is being open with your co-residents, because they have shared experiences, and knowing that someone else is going through the same thing you are is incredibly helpful. So just talking to your co-residents, say, I had a really bad day. This happened. Has this ever happened to you? And most of the time they'll say, yeah, I had this one case. It's a lot about just listening and validating their emotions and things like that.
Having the specifics heard and acknowledged is less important to me than just being heard. I have other residents that I've processed things with, but people knowing at least that I've had a difficult day and just need someone around to sort of spend a little bit of time with that's enough for me. Whereas some people sort of benefit from actually talking through the sort of situations and actually having some sort of external processing.
This difference that John brings up, the difference between having someone listen to you and having someone listen and respond, is worth elaborating. For instance, whenever my fiancée Erica has a tough day and wants to come home to talk about it, she's not looking for advice. She's looking for my ears. All she wants to do is talk to me. She wants my acknowledgement and not my input. On the other hand, my friend Pat, who's a mechanical engineer in Houston, when he calls me to talk about his problems, he's an engineer. He's looking for solutions.
All right, so how do we do this thing?
So we talk it out, and we come up with all sorts of ideas. But sometimes you don't even want to talk.
Sometimes not talking about it for multiple days is really helpful, kind of processing it, going home, not talking about it. And then when you're kind of ready to talk about it, having a kind of controlled conversation about it that's not really emotional can really help process what happened. And usually a few days later, you look back and it's kind of more clear.
making conversation can get in the way of internal reflection, and sometimes it can just make you more aggravated. John remembers tough days on an oncology service.
And those are some of the sickest patients in the hospital.
Dealing with patients who have leukemia or lymphoma, where he would get home after work and have to basically exercise his way back to sanity.
I would actually come home and then would see my girlfriend. She would open her mouth and I would just have to stop, get on my bicycle and go ride for a couple of hours to just process sort of what the day had been before I could really interact with another human.
I remember as a third-year resident rotating at the Children's Hospital for 2 months. Q4 call, completely out of my element, knowing nothing about children. I actually stashed a drawer full of Reese's Puffs and chocolate bars and leftover cookies from various educational conferences. And every once in a while, there'd be a banana. But mostly chocolate. All things in moderation, I guess. While there's not a one-size-fits-all approach to preventing or coping with burnout, a number of strategies have been helpful where we work. Strategies other than binging on chocolate that disguises itself as cereal. And after talking with Lindsay and John, I picked up on some common themes that worked for them. Theme number 1, be strong and emotional. Also know that being strong and emotional are not opposing qualities.
I definitely think there's something to be said about resilience because I get connected to people very quickly.
They appreciate the humanity that I bring to their experience in the hospital.
If I don't put up a barrier, I'm going to get burnt out by just the sheer number of things that can happen to people that you can't control. For me personally, I connect with people, but there's a limit to the amount that I allow myself to connect with people so that I don't constantly have such strong emotions about negative things that happen. And I don't know if that's right or wrong, but it's just how I think a lot of medical professionals are able to get through.
Do you think your patients would prefer a more resilient doctor or a more human doctor?
There's a part of me that thinks, oh, they think you are human, but then there's a part of me that's like, a lot of patients want this doctor who knows everything and is very confident and doesn't cry and doesn't get overwhelmed. So I wonder if sometimes patients would look at you as weaker because you cried. But I don't know the answer to that.
Yeah. It's hard to say because I think that, having gone through the amount of sort of clinical experiences we have thus far, the idea of what patients expect of us is not really universal. You see people who have had some really negative interactions with the medical system for a number of years and just want compassion. And you see people who have had family members who have been, part of difficult or potentially wrong medical decision making and just want competency in their work.
Number 2, admit defeat.
Confidence is so much more fragile than curiosity when you're a resident.
The quicker you learn to learn from your mistakes instead of just continuously ruminating on them, I think really helps prevent burnout, because if you're constantly dwelling on all the things you got wrong or all the things that people might think about you because you got something wrong, that's just going to be a recipe for disaster as a resident.
Theme number 3, life maintenance. It kind of goes by the wayside during residency training, not to mention losing a lot of your passions, which can get shelved for the 5 to 10 years of residency and fellowship. Unless, instead of finding time to do these things, you make the time.
John and I were saying, we do a lot of things on call, on the lighter call rotations, where you can either just read an article or you can do something fun and creative and try to write something. And so I think neurology in general is just really supportive of that kind of activity. Especially here, I think that a lot of people will read what you write and they'll support what you do. And so that's been a good outlet, I think.
When I'm just trying to survive is actually when I do the worst, and whenever I'm the worst at surviving, the worst at thriving, whenever I sort of just have a singular task to sort of accomplish, like just be a resident, just be an intern, just sort of get through my day, that's actually when I do the worst. It's whenever I have other things that sort of enrich that experience that I'm actually able to sort of flourish in my primary task.
I think that in general makes your day so much more enjoyable.
Number 4, me time. I know it's not in your blood, having chosen this extremely selfless profession, but if you don't take care of yourself, how can you be expected to take care of others? Let's think about it this way. As a doctor, or even a nurse, or an AP, a pharmacist, or social worker, when you're committing these crazy hours and surrounded by patients, really sick people who depend on you to return back to health, you resort to using a lot of your left brain. God, I really hate using that, but it's true. That more abstract, creative half to your mind, your right brain, it's going to atrophy unless you feed it with some sort of activity.
Oh my gosh, it's so important.
A lot of people around me are really creative and they're doing really awesome things, and it kind of motivates you to think about what makes you happy and what makes you happy outside of work.
So I own my home, and doing projects around my house, and you do a lot of deducing and diagnosing, but especially as a more junior resident, you're not building a lot. You're doing a lot of diagnosing and maybe a little bit of therapy.
I find one way that I cope, which my husband Phil will agree with, when I'm unsettled at work, I come home and for some reason I feel like the house is unsettled. So cleaning happens, I reorganize everything, I make him and I move all the furniture around, I redecorate, I go to Home Goods and get a bunch of stuff and switch out all my throw pillows, and then when that's settled, and then I kind of feel settled again. So it's kind of it's fun.
If you have a tough day, you're welcome to come over to my house
and reorganize your house. Yeah, I'm always doing something. He's like, you put the couch there 2 weeks ago. It's not going to work there.
I actually find cooking to be really therapeutic too. I do a lot of cooking. That's one of my main sort of hobbies. I think it's another sort of creative thing. It's another way to use your brain a little bit differently. And I'm eating better. I'm taking a little bit of time out to focus on a singular task as opposed to residency where you're focusing on 17 tasks at once.
Would you say that preventing or overcoming burnout is an active process?
I don't think that it's an intervention or a situation where you need to go and have some sort of formal setting. I think it's just sort of acknowledging in the moment that somebody is going through something or is not sort of themselves that day because they've had something they've been dealing with.
So at least 4 themes have come up. Be strong and emotional, admitting defeat, or at least recognizing one's own limitations, life maintenance, and me time. But you also have to find work fun, because ultimately you are spending these 80 hours a week doing this thing, residing in this sterile environment, surrounded by illness and death and defeated personalities and never-ending checkboxes. Something you had to have done before all this is what brought you here.
I was a TA for a few classes, and in medical school I was always, helping with anatomy lab or helping with certain classes, and I find a lot of enjoyment out of that, and it's something that I want to do in the future. I would love to just do a lot of teaching at a medical student level, and I found that intern year and so far JAR year, it's been harder than I imagined to fit that in because you're still learning, and it's really hard to teach people things that you're not totally confident with. And so I feel like having an outlet to write about cases or do that form of teaching gives you the confidence to then go ahead and teach.
So there was this older part of you that was passionate about teaching and science and medicine, and you sort of revived it. What were you thinking about?
Wouldn't it be fun if we did something with all these cool pieces of information that we hear to disseminate it to the residents? That would be fun. And John's like, well, why don't we just do it?
It was kind of a combination of things. I think that it's hard whenever you're feeling a little bit more tired and you don't have a reason to sort of dig a little bit deeper into the literature about things. It's difficult because we have so many unique experiences at the different hospitals, but they don't translate. The main academic hospital is this sort of main center where a lot happens, but there's also interesting things that happen at the other hospitals or other services that's nice for us to kind of share amongst ourselves, which I really enjoy. And it really was, we were just sitting there and Lindsay was expressing a desire to do something like this, and I was like, well, we could just do it.
Yep.
There's nothing stopping us. That's all the motivation we need.
I love that. Nothing is stopping you. That's all the motivation you need, and it led both of you to create the Cortical ribbon. Can you tell me about that?
So we are the entire editorial staff.
So basically, we welcome any and all people to kind of submit any topics that they've heard about on rounds or anything like that. And we also kind of, throughout the week, will write down little small tidbits of teaching that we've encountered on rounds or things in professor rounds that were brought up but not really elaborated on. And basically we pick 1 or 2 really interesting cases that we have physically seen and have the primary data for.
What kind of cases?
There's a case of the week, which we find interesting, and it's usually involves some radiology. So it's kind of teaching the radiology with the case. And then there's a clinical teaching pearl with each case. So, for example, we had a patient with multiple cavernomas, and one of the clinical teaching cases is he presented with a stroke, very unsafe to give TPA. What does it look like on MRI, CT, etc.? Mm-hmm. We also do what we call the Price is Right review, which is kind of a pun on our beloved program director because he's very into the right exam.
His name also happens to be Dr. Price, so the price is right.
And then we like to throw in a haiku in there just to kind of keep it fresh, keep it fun, get some creative energy flowing. And usually it's a joke about some consult we get or the aspirin and Plavix debate and stroke.
Did I ever actually tell you where the idea haikus came from?
And the funny thing is that since we started sending out these haikus, the clinic now, the neurology clinic, has these haikus written on the board. And I didn't know if it was related or not. And they're trying to create their own on the board, which I think is fun. It's kind of like
no idea.
Our jokes and our teaching points are starting to disseminate, which is really fun.
Yeah.
Yeah, it does sound pretty cool. A nice way to keep that right brain from atrophying for you and for the attendings. Why did you choose to call it the cortical ribbon?
Well, so the cortical ribbon sort of in its original definition is this actually really sad thing, which is in Creutzfeldt-Jakob's disease, I believe is the exact, I don't remember the exact pronunciation, but CJD or the prion disease. Basically what happens is there's this little ring of changes on an MRI that sort of lights up the brain as like a little ribbon all the way around it where the cortex lights up. But somehow it just really flowed and felt kind of quite nice as a way to sort of describe sort of these little snippets of knowledge. And we don't imagine it as like a bright layer of death. We kind of think of it as like an interesting like little rainbow kind of lining the brain.
Yeah, and also we didn't really like think too deeply. It was like a kind of we liked it because it was very free flowing, and we're like,
yep,
great.
Yeah, I never knew that your newsletter was referencing a prion disease. That's actually kind of disappointing. My original thought when you guys told me the name of it was that you were actually just describing the layer of cortical neurons overlying the cortex, and that's kind of where all the magic happens.
That's fine too.
Yeah, you can edit it to where that actually is what you include there.
Let's say it's all the layers of depth that go within the cortex itself, and it's all the layers of residency and things like that. So it just seemed like a fitting title.
But actually, it's just a spongiform encephalopathy.
Yeah.
Shoot.
So besides you and Lindsay, who else is helping out?
We're sort of putting most of the effort into it right now, but our hope is over time that it's going to be sort of a forum for dissemination of interesting information and also a nice repository. Mm-hmm. Yeah, we're a good balance.
I'm the straight and narrow, and I call him a little bit more curvy.
Yeah.
So I keep him more straight.
Called John Curvy.
I do.
I like my curves.
It's just like a fun outlet for us right now, and we'd love to get other residents at other hospitals to read it and maybe contribute what they're seeing so it can become more of a repository of interesting neurologic cases across the country versus just in Philadelphia.
Yeah, because I think I'm sure every place has their own way to do this. But I think that sort of the newsletter and now the blog format really lends itself to kind of teaching and sort of like high yield teaching because just these little cases.
Whatever your outlet is, whether you are creative and enjoy poetry, or you're into research or cooking or family, keep it alive in you. If I could leave you with any last message as we're about to wrap up the show, it would be that it's so important that you remember who you are. Remember what it is that drives you, that gets you out of bed every morning and drags you into the hospital to face these challenges day in and day out. Because ultimately, you chose a very selfless and honorable path. And I'm not trying to justify this because it's the path that I chose, and this doesn't apply strictly to physicians either. I'm talking about nurses and social workers and pharmacists, physical and occupational therapists, speech pathologists, advanced practitioners, anybody who decided at some point in their lives, you know what? I'm going to spend the rest of my life helping others.
We really don't view medicine, I think, as what it should be here in the United States. Like, it's a public service. Like, I'm doing a service to my community. I'm doing a service to the people around me. As much as I get my own sort of personal intellectual fulfillment and I know that I will have a job. These are all nice things. But in the end, like, medicine is a service, and like I'm actually choosing to spend my life kind of serving other people.
That makes it worth it.
Thanks everybody for tuning into our show this week. Hopefully, amid all your other obligations, you're still finding time for fun things like listening to podcasts or even taking advantage of your own creative outlet. If you like the show this week, let us know by rating Brainwaves on iTunes, Google Play, Stitcher, Spotify, or wherever you get your podcasts. This week's episode was produced by John Best and Lindsay Raab. Senior producer would be me, Jim Siegler. Music courtesy of Daniel Birch, Little Glass Men, The New Valleys, Rod Hamilton, Chris Zabriskie on the piano, and John Watts on the guitar. That wraps it up. From Philadelphia, Pennsylvania, I'm Jim Siegler for Brainwaves. See you next time.